Hey, what's up, Charlin family? Hope you guys are doing good. Happy Tuesday. Got JT here, Executive Director, and myself, Charles. Hope you guys are doing good. Thanks for hopping on. We've been usually doing the Hospice Live one-on-ones, but we figured we'd switch it out this week and talk about something that me and JT and a lot of our team talk to families throughout the Metroplex on is healthcare at home and what is it? There's a lot of confusion when it comes to healthcare at home, from the home health side to the hospice side to the personal care side to the palliative care side to all the sides. And our heart is to help educate you and educate anyone who's watching so that you have a good understanding, a very easy way to understand what is healthcare at home. And if your loved one needs it, what needs to be done, and the resources that you need to get it done. So, JT, man, how's it going? How's the day going so far?
Yeah, yeah, just getting through the week. Got the World Cup coming up this weekend, so
Yeah, it's gonna be
yeah,
fun actually.
yeah, it'll be sweet. But yeah, like Charles said, this is a guide not just for your parents or maybe your aunt or uncle, but we've met with different people in the community, parts of city councils or financial advisors, because this is knowledge that's more than just for you know your loved one that's in the hospital. This is just good general knowledge because you know all of us will need it in some
Yeah,
form or fashion one day.
yeah, 100%, 100%. And I think it's crazy because we all talk about like this having an understanding of how to change a car, the oil in the car, right? Or just even the windshield wipers. Like these are basic things, but understanding healthcare at home for your loved one, at least the basics, is just super important. So, yeah, let's get right into it. Let's get into the stats, JT. I know we always like to talk about stats. If you want to run them through.
Yeah, yeah. Charles always kind of prefaces us with this, but by 2030, 1 in 5 people in the U.S. will be over 65, and we know for us specifically here in Plano, by 2030, 1 in 2, 50% of people will be over the age of 65, and so that aging population, some people call it the silver tsunami. Um, all that is going to do is, need more care at home, more healthcare workers, and more education in the community. And so 90% of people want to age in place. That means at home, at their adult son or daughter's house, in an assisted living facility, independent living facility, memory care facility. There's different places that you can age, and there's different ways you can be taken care of in each of those places.
Yeah, yeah, and that's a good point. Like, a lot of people say like, where's my loved one? Like, if they need help, where are they gonna live? Where are they gonna go? And there's so many places. It's like 90% of people, adults, want to age in place. It's crazy. I mean, there's no place like home. you know.
It's true.
Yeah, yeah. So ideally, JT, like, why does this matter? Why do you think this matters to like everyone in general?
Yeah, like we just said, we have the aging population, but it's more than just healthcare. It's your finances, it's your mental health, it's being that sandwich generation. You're the caregiver for your older parent, but you also have kids. Um, all those things put on different stresses in different ways, and so you'd be surprised. Like even some healthcare professionals don't know the ins and outs of what's available at home. Doctors, they can specialize in what they do, but like we've said, this is good general knowledge so that you can lower that stress level, keep your finances in order, but also make sure that your loved one's being taken care of at home where
Yeah.
they want to be.
Yeah, 100%. Yeah, I think over the years, the biggest stressors that we hear when it comes to healthcare at home is money, right? Because money is what's needed to take care of someone. And so what we like to do is we like to help educate on everything that insurance can cover and should cover and maximize insurance to the most, but then understand that there's gaps in healthcare because insurance will only cover so much. And this is kind of where this pillar that you guys see right now is pivotal, right? So you have all the healthcare things that could happen at home. You've got home health on the bottom, the foundation. You've got personal care, you've got palliative care, and then you've got hospice care. And so when you're looking at all of these pillars, these are the things where insurance will cover some aspects of it, and then insurance won't cover some aspects of it. So families are kind of left in that gap feeling of, oh, wait, the nurse is only coming out a certain amount of times, when who else is going to come out and help my mom or help my dad? And the reality of it is that a lot of families don't know these gaps. And so I would say the quicker you could actually like understand it ahead of time, then you can plan. And you were talking about that, JT, financially, like it's so important.
Yeah. Yeah, and like Charles said, not just insurance covering or not covering this, but actually like agencies that only do some of these things. Like some agencies only do hospice, some only do personal care. At Charlin, we do all the above, but that's not always common. And so knowing like, okay, if your loved one's on home health and has a nurse and a physical therapist, like what about baths or what about medication reminders or light housekeeping? Like, where does that kind of fall in? And so that's what we'll break down here with these pillars, because there are different levels of care at home, of course, just
Yeah.
like any other healthcare facility.
Yeah, 100%. And over the last couple months, what we've been doing is doing some hospice live 101s. And those hospice live 101s are talking about patients that we've served or patients with certain scenarios like the ones we've taken care of, and kind of redoing their stories so that you can kind of sit in their shoes and understand, oh, wow, this is what hospice is. And so what we'll do today is that we've got like 3 different patient scenarios that we've talked about over the last couple of months. We talked about Marcus, Evelyn, and Danny. And if you see these pillars, we're going to talk about Danny's time utilizing personal care. We're going to talk about Evelyn's time utilizing hospice in this pillar. And then we're going to break down Marcus's time, him having ALS and home health and what that's like. So at least you can kind of understand those aspects. And then we're going to do our best to kind of show you the gaps, so that way you know, oh wow, this is what insurance will cover and this is what it won't cover, so that you can be prepared to age properly in place. So JT, is there anything else you could think of on that?
Oh,
Yeah,
yeah, we
yeah,
can get into those stories and then build from there.
yeah. Let's do it. Let's do it. All right, so let's talk about home health first. Let's talk about Mr. Marcus. If you were on the journey with us these last couple months, we talked about Marcus's battle with ALS. And so let's highlight Marcus's story real quick. And so Marcus got diagnosed with ALS, and ALS is a degenerative disease, and it's terrible because it wastes away your muscles, and all of the neurons that are firing to hit your muscles are not talking to each other. So basically, it's a slow decline. And so we were honored to take care of Mr. Marcus for home health services. And so what happened was is that in Marcus's situation, he had a Medicare Advantage plan. And so if you guys are familiar with Medicare, there's Medicare Part A and Part B. Part B covers for home health services, and he decided to opt into a Medicare Advantage plan. So that Advantage plan specifically has to be contracted with a certain home health for him to receive services. And the second thing is he had to have a doctor write an order, and that order had to state skilled nursing, PT, OT, or whatever is needed clinically. So Marcus had to be homebound, which means it doesn't mean he can't go anywhere. I think JT, we talk about this all the time. It's like homebound doesn't mean like you're bedbound, right? It just means it's hard for you to leave the house. So Medicare requires these certain criteria to say, okay, it's hard for you to leave the house. You need to have an assistive device or someone to help you leave the house. And it's a taxing effort, or it's hard to leave the house, and you need a skilled need. So skilled is something that can't be performed by a layperson. Nursing, you got a degree for nursing, physical therapy, OT, those things that are clinical. So not housework, not an aide coming to help clean up, not an aide coming to do chores or driving back and forth to the doctor. This is what home health is. This is what home health is, and this is what home health was received from Mr. Marcus under insurance. And so he received home health to help slow the decline and keep his quality of life with his diagnosis. And it's amazing. There's tools that were given for physical therapy. There's OT that's given to help his upper extremity and help put his socks on and do his activities. And so home health is meant to be there, not forever, but it is meant to be there to help for 60 days of care, and then recertified if there's goals that are continued to be met. But yeah, JT, then.
Yeah, and a key thing to remember here from when you're thinking about all your options at home. This is skilled care. So, like Charles said, nursing, therapy. But what that also means is there needs to be a doctor that oversees it. And so, if you're watching this thinking about your loved one or your aunt, uncle, mom, dad, like, do you know who their PCP is? Are they accessible? If you call their office, is it an answering service that never calls you back, or is it a nurse or an MA at the front that can answer your questions quickly? These things are important early on because when a home health company tries to get involved, such as Charlin or another home health, they need to be able to coordinate with that doctor, because we'll talk about it later. But unlike hospice care, where there's a medical director over the hospice care, home health is with all these different doctors. And so, if anything changes, in Marcus's condition, if his medications change, if his symptoms change, the home health team will actually call your doctor for you and help coordinate on that. So it's just something to think about. If home health is taking a while to get set up or delayed, sometimes it can be because that doctor's office, maybe has too many patients, or
Yeah.
just based on that relationship you have with them.
Yeah, no, it's a great point. And I think that kind of leads us to like the gaps in home health that families talk about. One of the gaps is you see Mr. Marcus right there has a walker, right? DME. So what does DME look like? And so when it looks like durable medical equipment like a walker, wheelchair, hospital bed, that is done through insurance. And so the home health is not the one that gives those supplies or that DME. The home health is the clinical person, the clinical team who says, hey, I think you may need this, and then helps to coordinate with Marcus's doctor to create an order to send it to a durable medical equipment company. Now, depending on what insurance will say yes to or not, a lot of times it may take a long time. And we see that a lot over the years is that insurance may not approve. They may approve a walker, but they won't approve a wheelchair. Or they may not approve both of them, and they won't approve the hospital bed either. So a lot of times what we see and we talk to families is like a lot of times you're going to see sometimes renting equipment is better, and that's cash. And so it just depends on how quickly you need that information. So you could go to your local DME companies, or sometimes Amazon's good, but it's also good to go to a place where you could kind of look at it, look at the equipment, and take a look at that. So those are some of the gaps that we see. Another gap that we see is the type of therapy that's needed. And so the aggressive type of therapy is not going to be the same at home like it was if Marcus had to go to a rehab, right? So when you're at a rehab facility, you could get therapy daily, right? You're there for 2 to 3 weeks, and you're getting max therapy, max OT, match speech therapy. And then once you are discharged home, then when you get home, it's a spaced out type of therapy plan because the goal is to help improvement and functional mobility. So that's a big thing, a big gap that I think families are like, well, I need more therapy. I need more therapy. Well, insurance will only cover and authorize so much therapy in a home setting. If you need more aggressive, strong therapy, then the recommendations could probably be go to a rehab, or go to outpatient therapy, right? So those are some gaps that we see in Marcus's care when it comes to home health. So, but yeah, anything else you could think of, JT, when it comes to
No, I don't,
gaps?
but yeah, just the one thing you touched on, the frequency of who's coming to the home. That's where, as a home health agency, we're limited the same way by that insurance for how often our nurse can come, our therapist can come. That's where it can be offset. We talked about those pillars, that personal care pillar, which we'll talk about with one of our other examples. But that's where you get that everyday support. So, if you need someone to get Marcus out of bed every day at 8 a.m., help him get up, help him shower, use the bathroom, get him dressed for the day, groom him, help him shave, and then give him breakfast and lunch. Like, you can hire someone to do that 4 hours, 5 hours, 8 hours at a time.
Yeah.
And sometimes there's long-term care insurance that'll cover that. If they're a veteran, the VA contracts that way too. But usually it's paid in cash at an hourly rate, depending on the personal care or home care agency that does it. And so that's one of those gaps, where, like Charles said, it's not a rehab facility where there's 24/7 eyes on you.
Yeah.
And if there's not family members that are able to be there all the time and help with all of those things, that's where that can kind of come in and help.
Yeah. Yeah. No, great. That's it. And that kind of segues to Mr. Danny. So we were talking about from a personal care standpoint. This is another story that we talked about the last few months, and Mr. Danny had a stroke. And so now with him having a stroke, he was getting home health services, right? And so just like Marcus, there's the gap in between, him living at home with his spouse and not able, she can't do everything, right? And so the nurse is only coming in there from home health standpoint, maybe once or twice a week. PT's coming out twice a week, OT twice a week, but there's only so much that insurance will authorize. So the gaps is where we talk about personal care services. And so, JT, you want to highlight a little bit about personal care services?
Yeah, personal care services are we have this question all the time with families because this is the first thing people think of, I think, when they think of like healthcare at home, help at home. Maybe they remember like grandma or grandpa back in the day had someone doing these things. And so in today's environment, what that looks like is it's a caregiver, either licensed, trained, maybe it's a CNA, certified nurse assistant, but these people will come out and assist with all the things we are just kind of mentioning: bathing, day-to-day things, light housekeeping. No one's replacing the whole garden or like doing anything on the house, but like,
Construction work.
right. But they'll like, change linens, clean the bathroom, clean the living spaces, the kitchen, places that the patient is frequently in. And so from an agency side, you can hire an agency that can guarantee, that they're background checked, trained, going to be there if they call off sick. Some people will hire these privately because it is cheaper that way hourly. Sometimes that's, through Facebook, through family, friends, word of mouth. So there's different ways these caregivers can come into play. But what they do is just being there, kind of eyes on your loved one, and helping with those daily living tasks that insurance unfortunately doesn't cover. There is long-term care insurance. So if you ever have heard one of your parents or someone mention long-term care, reach out to them, ask what their provider, their policy is. There's a bunch of them out there, but those plans are built to either help offset facility rent costs like an assisted living, or sometimes even aid services like this. Because a lot of these agencies, of course, for schedules, they have a minimum hours requirement. So 3 hours, 4 hours at a time. But if you're just looking for like an hour here or there, that's where long-term care can help out with some of those costs. So
Yeah, no, it's I recently had a case manager ask me a question. She was saying, "Is it like, am I too young to get to like start thinking about getting long-term care insurance?" I was like, "No, that's actually the best. That's like the best time. Like honestly, like if you think about Danny or anyone else, they started probably putting into the plan in their 30s or 40s. At that time it was probably $20 a month or something, but now it's a little bit higher. But like they're able to put money, small money aside, so that when Danny needed it now, he was able to pull down 3 to 4 thousand, maybe $5,000 a month for his care. And so, pre-planning is so important. And a lot of times there's so many different plans, like with New York Life, I'm sure, like all the other types of Edward Jones, right? John Hancock, all the big ones. You can talk to an advisor and say, hey, if I put money aside now, is that money going to be tied away in a certain way where I only can use it for long-term care insurance? No, there's so many different flex plans that are now available for families. And so, the hardest part that we see, JT, is that when this aspect of the gap in healthcare is there and there's no funds at all, that's the difficult part, because then we see all the hard stories, the tough situations, but that's where we say, okay, hey, let's talk to family, let's talk to church members, family members, let's talk to someone a neighbor who can come in and sit with Danny for like 2-3 hours because nobody's there to help. Like that's where you have to really pull on the village, your the people that love you or love Danny or love people like that to kind of guide through this. So yeah, great. I mean, it's a great question for her. I was like, no, you're not too young to get a plan. And number two, please do. So, but yeah, in this situation, Danny is receiving personal care services, getting home health, getting in a combination with the skilled services, nursing, physical therapy, PT. And then in between those gaps, while he's trying to get back from his stroke and recover from his stroke, he's paying for someone to come in and help with his wife on those services like meal planning, taking him back and forth to the doctor, and that's where that aspect of care comes in. Yeah.
Yeah. Yeah, so we've talked about non-skilled care, right? And that's so because we talked about the doctor earlier, non-skilled care is not overseen by a doctor. So if you
Yeah.
want to pay cash and you want someone to be there as much as you want, like that doesn't have to be signed off by a doctor. But like Charles just mentioned, it goes hand in hand with the skilled care sometimes, where it's like just extra support. But the last patient we'll talk about, we're talking about like what we'll call the highest level of skilled care at home, and that's talking about hospice care. This is a benefit that Medicare has built for families to help them at end of life care. It can come at a lot of different times of people's lives, a lot of different ways, but it's there so that families don't have to go back and forth to the hospital, don't have to fight for these gaps that we see a lot.
Mhm.
Because as we'll kind of talk about with Miss Evelyn, hospice fills a lot of the gaps in a lot of ways, and lets the family be safe at home where they want to age.
Yeah, yeah, 100%. I think a lot of times, if you're watching this now and you've heard the word hospice and you're kind of scared and you're not sure what it is, or feel free to hop on our channel. We've had several weeks of walking through what hospice 101s are, and educating on what it is and what it isn't. But we'll do like a really quick summary in this situation. For Evelyn, she has Parkinson's disease, and it progressed, right? And so I think one of the things that families need to understand is that hospice doesn't mean death right away. Like if you look at this image, this is where she was in the hospital, right? And she received the news that she needs hospice care with her husband there. And the doctor's just saying that. So that image right there is devastating, because it's like, whoa, what is hospice? What does this mean? Like, I'm gonna die right now. And I think what we've tried to do, and a lot of the best hospices around the nation, what they do is they help educate to say, okay, number one, hospice is an evaluation that's performed and it's reviewed Evelyn's clinical criteria, right? So there has to be clinical criteria that's met for someone to qualify. So not just anyone can go on to hospice services. It is a benefit and it's a right if you have qualified underneath those clinical guidelines, right? And so in her situation, she had Parkinson's disease. All of her clinical markers showed that she qualified for hospice services. Now, once that is done, then she is admitted to hospice services under Medicare Part A. And that's where a lot of the help comes into play. And so you have a nurse to come out. Now, there's still gaps that we talked about, but a nurse comes out, does the admission, and creates a care plan. A nurse will come out 1 to 2 times a week, sometimes even 3 times a week. Oh, it's a fire truck. I don't know if you heard that. We're live. So the nurse can come out 1 to 2 times a week. Now, depending on how eminent she is, it could increase, right? And so the nurse goes out, does the admission, and then the beautiful thing about hospice is that you have a nurse case manager who's your quarterback to review all of her current medications. Now, the hospice becomes like a hospital at home. So now all the medications are delivered to the house. Medications, not just medications, but DME, so durable medical equipment that we were talking about before with Marcus. Now the hospice contracts with their own company and it can be delivered. There's no insurance authorizations needed. And then supplies, which is the biggest thing. And so like incontinence material, Depends, chucks, wipes, gloves, all those things are underneath the benefit of hospice Medicare Part A. And so that's a big help. And the goal is to keep patients and family members comfortable in this type of difficult season of not knowing what to expect. And I think that's the beauty behind it, is you have a team.
Yeah.
And so not just a nurse, but you have an aide. You want to talk about the aide a little bit, JT, as well?
Yeah, yeah, like Charles said, there's a team that's involved. So it's not just the nurse that's, like you said, quarterbacking it. There's the medical director overseeing all the changes that the nurse is recommending. But then with the nurse as well, there's a nurse assistant, an aide that can come out 1 to 5 times a week. Because, of course, on hospice care, there's more frequent changes in condition, changes in skin, things like that, that we need to see on a daily basis. And so that aide works closely with the nurse to report on those changes, help with bathing, grooming, things like that. But then outside of the clinic, I like to split it the clinical team. There's also like the social and spiritual team. And so those two members are key members, the social worker and the chaplain, who make sure, have you thought about a funeral home? Have you put a will in place? Have you done a DNR? Especially for the chaplain, that looks very different. Sometimes it's, they just want to pray with the chaplain. Sometimes it's they just want to play cards with the chaplain and they
Yeah.
don't want to talk about, what's next, what's after, anything
Some
like that.
Games of Uno and dominoes.
Exactly. So that's the social and spiritual side, and then some hospices will have a volunteer program. So if you're interested in volunteering, you can look at hospice agencies to meet these types of patients and be there for their family. But they serve a similar role to the chaplain and the social worker to be there, just to provide that comfort at this time. And so while there's a lot more in the team and they're there a lot more frequently than home health, hospice still is not, 24/7. They're available 24/7 clinically, like Charles said, it's a hospital at home, but like someone sitting there at the bedside, that's still where personal care, long-term care insurance can come in, and be there to help all day.
Yeah.
But usually what we see is there's a family member that takes on that role of being the primary caregiver of Miss Evelyn or the loved one in this case.
Yeah, yeah. I think that's a good point. Is I think a lot of times when we think about all of the things that insurance or Medicare covers, I like to think of it as the clinical oversight and the clinical care. Right. We talked about home health, we talked about hospice, and even palliative care. Right. All those things are the clinical oversight to make sure your loved one is clinically safe at home. Right. When you're looking at things that do not involve someone who is went to school, who is an expert in their craft, when you think about those things, if anything can be done that's outside of that, insurance and Medicare will not cover those services, right? And so that's where we kind of see the gaps in care. And sometimes we have families say, like, I thought hospice was going to help, you know, with everything at home. Well, the goal is it's not going to change that the fact that this is going to be a very hard season and it's a tough season. Death is not easy at all, right? And just like birth isn't easy, right? The same things go hand in hand. You need clinical guidance. You need a team that can guide you through what to expect next. Hey, think about this. These are some things that you need to look out for when this happens. This is what it means. It doesn't change the fact that it's hard. It just kind of eases the pain of not knowing what is next. And so yeah, I think these are the things that we see a lot is there's so much good support in these areas of what Medicare and insurance covers, but also finding the right company because not every company is the same and no company is perfect. That's the thing. Even the best companies like make mistakes. Everyone makes mistakes. But at least if you have someone that you can reach out to within the company or find another company and figure like how do we go through this together, then there's a way to help. And so yeah, I think if we look at the pillars again, we talked about home health, personal care, and then let's touch on palliative care, right? So when you're looking at palliative care, we talked about Marcus on home health, and then we talked about Evelyn on hospice care. What is palliative care? And so palliative care is a type of approach, right? So let's say Evelyn had a good example. Let's say Evelyn has had cancer, right? And so she was wanting to continue to do chemo treatment, infusions, IV hydration, IV meds, right? And continue to move forward and fight, which is, we see a lot of good things too. Like some families and some patients beat cancer, right? And so palliative care is a type of approach to coordinate all of what's going on from a pain management standpoint, from a care coordination standpoint. So some companies, what they do is they have a nurse practitioner who oversees clinically of what's going on, because you have the PCP, you have the oncologist, you have the neurologist, you have the cardiologist, you have the all the ologists, right? You have all of the doctors coordinate all of these things happening, and it can be confusing. So that nurse practitioner, that palliative care team is just really to be the glue. So there's no, when we're talking about hospice, there's not the benefit of having meds. There's not the benefit of having equipment, right? That's a hospice Medicare type of benefit. The palliative care is more for that coordination and to help with guidance from a nurse practitioner from time to time. to help lead you through. So it's a different type of approach when it comes to that palliative care program that most companies utilize. So yeah, is there anything else you could think of with those pillars, JT?
Yeah, just the last, I was kind of thinking about this yesterday. We get asked like all the time, like when we explain the benefit of hospice, all these things you just heard,
Yeah.
and we hear like, so who's paying for this?
Yeah.
But
Woo.
I was thinking yesterday, I was like, actually, like the patient is for the last 60 years,
Yeah.
they've been paying into Medicare.
Yeah.
And so now, like Charles said, it doesn't mean immediate death. I always reference a hospice 101 we did where when we went out to the house, the guy was mowing his lawn.
Yeah.
We're like, oh, is the patient there? And he's like, looking
I'm
at
here.
him. And I'm like, dang. So I think when you hear that word, like you were saying earlier, Charles, like it's scary, and it's like, no, that's not what this is. This she's still got, time with us,
Yeah.
like
Yeah.
she probably does, and it looks different for everybody.
Yeah.
But that, like we've been saying, it's a right and it's a benefit that hopefully after seeing something like this, families can at least begin to think about or utilize as they need it.
Yeah, yeah. And I think another thing is, I'm glad you said that too, is, we talked about still the gaps in that, right? So like, even though hospice, let's say someone is qualifying and admitted to hospice, we see families just like Danny had personal care while on home health, right? Because there is those gaps, right? Because clinically qualifies for hospice services, needs extra help, but is only getting a nurse out 1 to 2 times a week, and aide coming out 5 times a week for specific aid care plan bed baths and hygiene. And that's usually 45 minutes. So you have 24 hours in a day where you're only having probably 3 hours, maybe 2 hours in between the team who's coming in and coming out to make sure that everything is on pace for the care plan, right? And so you have that gap, and that's where you see a lot of families will pay someone to come in. They either pay someone that they found on Facebook, or we talked about before, or someone that Craigslist. I don't know if Craigslist is still around. Is it still around? No.
No. I
Yeah,
don't think so.
yeah,
It could be.
yeah. So it's just or they'll pay a company a little bit higher, right? That higher fee is to really, they don't have to worry about someone calling out the caregiver having a flat tire. Like they'll figure it out, right? And so that's kind of what families do. And so yeah, I think when you look at, I think when you think about healthcare at home and you think about senior care at home, it's just all about understanding a little bit of the whole, all the pillars. Because if you have a good understanding, you can make an informed decision. And I think the worst things that we see all the time is you're at the hospital. Actually, you're not even at the hospital. You got a phone call from your dad that mom's at the hospital out of nowhere, now needs home health or needs hospice or needs something, and you're like, what? And you're literally at your son's game trying to like figure this out all in one swoop, and you have no idea of anything. And I think that's why we're passionate about at least giving this information to families to help get a good understanding. So
Yeah, and so um, going off that, that's a good segue to
Mhm.
like, how do you initiate this? What do you do next? If any of these stories sound like someone you know, or maybe even yourself, like what do you do? For us specifically at Charlin, we serve Dallas Fort Worth. So if you live in Dallas Fort Worth and you're like, man, I just watched this and like that's me or that's my dad. Like if you call our number or go to this website, you can talk to someone on our team 24/7. If you're outside of DFW, or you want to do this but not with us, that's your right too.
Mhm.
But talk to your doctor about it. Sometimes they know a good home health or a good hospice that they've trusted over the years. Ask your friends. If you heard one of your family friends had someone on hospice, ask them like, oh, what hospice
Yeah,
did you use? They might say, well, the hospital set us up with this one, but after a week or two we actually went to this one. Like we hear different things like that. But it's always good to trust who you learn from, trust who can educate you or that you've trusted over the years. And so that being said, our team is here to help in all those pillars that we just kind of went over. But sometimes you got to do your research, go deeper into YouTube, Google, whatever it might be, to make sure you're making the best decision for your family.
yeah, yeah. Yeah, no, it's perfect. Yeah, it's I hope you guys enjoyed this. It's good to hang out with you. We gotta get back to work, so but yeah, hop on every time. We'll be on Tuesdays. If we can't do every Tuesday, we'll be at least a few Tuesdays a month. And you can log on to our YouTube channels, Instagram, Facebook, TikTok. Shout out to Tina. She's our social media person who does all the good stuff. But yeah, thank you so much, guys, and look forward to seeing you guys soon. And blessings. And until next time, bye.
See y'all.